I mean, think about it like this. If you tried to stretch your hamstring, um, even just 50% past its physical limit, you wouldn't just be in, a little bit of pain.
Oh no, you'd be going straight to the emergency room.
Right. You'd have a catastrophic muscle tear. But, and this is wild, during the final stages of childbirth, there's a very specific muscle in the female body that is forced to stretch over 300%.
Yeah, honestly, the biomechanical data on this is just unbelievable when you first look at the numbers.
It really is. And welcome to today's deep dive, by the way. Today, we're looking at a stack of incredibly detailed sources. We've got clinical guidelines from the National Institute for Health and Care Excellence, or NICELIS, plus, some really complex biomechanical research papers and extensive medical reviews.
And we're using all of this to tackle a very specific, very personal, and honestly highly whispered about question.
Exactly. We are asking, can a prolonged second stage of labor, so that active pushing phase, cause lasting vaginal laxity?
Which is an issue that affects millions of people globally, right? But it just routinely gets brushed under the rug as, like, another unfortunate reality of having a baby.
Yeah, it's just accepted. So our mission today for you, the listener, is to separate the actual medical facts from the frankly aggressive marketing fiction out there.
Right, because there is a lot of that targeting new parents.
So much. We're going to look at the exact mechanical forces applied to the body during a long delivery. We'll analyze how common medical interventions change your risk of injury, and most importantly, what the evidence says can actually be done to fix it.
So to really grasp the mechanics here, we first have to completely abandon the idea that the pelvic floor is just a simple, flat sheet of muscle at the bottom of your torso.
Yeah, it's not a trampoline. Let's visualize it more like a complex suspension bridge, or maybe like a really intricate, multi-layered hammock.
I like the hammock analogy.
Right, and this hammock is made of interlocking muscles and heavy-duty ligaments, and it's actively holding up your major internal organs. We're talking the bladder, the uterus, the bowel.
It is doing some serious heavy lifting every single second of the day, just fighting gravity alone.
Exactly, and at the structural core of that bridge is this vital group of muscles called the levator ani.
Yeah, the levator ani. And if you look at an anatomical model, they form this very distinct funnel shape right at the base of the pelvis.
And during the second stage of labor, the baby has to pass completely through the center of that funnel.
Right, and to allow that to happen, a highly specific inner portion of this muscle group, it's called the pubovisceral muscle, it has to undergo extreme deformation.
Which brings us back to that staggering number. The research shows this specific muscle has to stretch up to 3.3 times its resting length.
Yeah, over 300% of its baseline state.
Which just defies basic logic, right? I mean, a skeletal muscle simply cannot stretch 300% without snapping entirely. It's like an overpulled rubber band.
It is. But to achieve that level of elasticity, there's actually a complete temporary physiological overhaul of the tissue itself.
Like it fundamentally changes what it's made of.
Basically, yeah. The mechanism behind it is this biological concept called viscoelasticity.
Viscoelasticity. Okay, break that down for us.
So in late pregnancy, you have these huge hormonal shifts, right, driven by hormones like relaxin and progesterone. And they trigger profound molecular changes that actually alter the physical properties of those pelvic tissues.
So your body is actively remodeling the structural cables of that suspension bridge, just anticipating this one massive load.
Down to the microscopic level. So think of the sarcomeres. Those are the basic building blocks of the muscle fiber. Think of them like a row of overlapping, interlocking gears.
Okay, gears. Got it.
During late pregnancy, that changing hormonal environment allows these gears to slide much further apart without actually disengaging from each other.
Oh, wow. So they stretch. But hold on.
Exactly. And at the same time, the extracellular matrix, which is the supportive scaffolding around the muscle cells, it massively increases in volume.
So it acts almost like a gel.
Like a gel or a lubricant? Yeah. It allows the muscle fibers to just glide past one another. So the tissue goes from being this rigid, load-bearing structure to becoming highly pliable. It's stretchy.
But, I mean, even an entirely remodeled, super lubricated suspension cable has to have a breaking point, right?
Oh, absolutely.
Like if you apply the load too quickly or the force is too violent, all that viscoelasticity can't save it.
Right, because viscoelasticity is entirely dependent on time.
Time. Okay, why time?
Because if the stretch happens too fast, the tissues are robbed of the time they need to safely adapt and deform.
That makes sense.
And more crucially, The danger really peaks if a woman bears down and pushes while that levator ani muscle is actively contracted.
Wait, so if the muscle is trying to flex and shorten at the same time, the baby is pushing through?
Exactly. When the muscle fibers are trying to pull tight, but this immense opposing force is simultaneously stretching them 300%, the mechanical tension just rapidly exceeds its tensile strength.
Oh, I see. It's like pulling on a thick, taut mooring rope on a ship instead of pulling a bungee cord. Something is going to give way.
Yeah, something gives way, and when that peak tensile strength is surpassed, the muscle doesn't just, overstretch. It suffers a complete structural failure.
It tears.
It literally tears completely off its insertion point on the pubic bone.
Wow.
Yeah, in clinical terms, this catastrophic failure is called a levator ani avulsion.
Tearing right off the bone. That is it's a visceral, violent injury.
It really is.
And understanding that mechanical failure, that connects us directly to the core question of this deep dive. We're talking about a prolonged second stage of labor.
Right. And clinical guidelines usually define a prolonged second stage as lasting over an hour for someone who's delivered a baby before.
And what about for a first-time mother?
For them, it extends beyond 2 to 3 hours.
2 to 3 hours of active pushing. That means putting that complex suspension bridge under maximum tension for a highly dangerous amount of time.
Yeah, the sheer time under tension becomes the primary risk factor here.
Because the longer it goes on.
The longer those muscle fibers are held at their absolute mechanical limit. And that just greatly increases the statistical probability of that avulsion injury.
Okay, so we've established the structural tear. The muscle cable has detached from the pubic bone. But I want to bridge the gap here between, a biomechanical failure and the daily reality for the patient.
Right, how it actually feels.
Exactly. How does a muscle detaching from a bone translate into this chronic physical sensation of looseness or that lasting vaginal laxity that people report months or even decades later?
So the sensation of laxity is directly tied to the size of the central opening the baby passes through. Anatomically, that's called the levator hiatus.
The levator hiatus. So that's the actual gap in the center of the hammock.
Exactly. And in a healthy pelvic floor, when a person is actively straining, that hiatus might measure around 2.5 centimeters across.
Okay, 2.5 centimeters. But when that pubovisceral muscle forcefully tears off the pubic bone?
Well, the anchor point that normally keeps that opening pulled tight is just completely gone.
So what happens to the opening?
With the anchor destroyed, the opening permanently enlarges. Research shows the hiatus can widen to over 4 centimeters in diameter.
Almost double the size.
Yeah, and this vastly enlarged hiatus is the direct physical cause of vaginal laxity. The architectural support base of the pelvis has fundamentally widened, so there's just less tissue to support the structures above it.
It's honestly incredibly similar to the collar on a favorite cotton t-shirt.
Oh, that's a perfect way to look at it.
Right. Like if you stretch that collar out too many times or you catch it on something and pull it violently, those interwoven threads snap. It loses its elasticity.
Yeah, and it won't snap back into a tight circle against your neck no matter how many times you wash it.
Because the structural integrity of the fabric itself is just fundamentally altered.
And when that structural collar is permanently stretched out in the pelvis, the daily symptoms for the patient become profound, and they're inescapable.
What kind of symptoms are we talking about from the sources?
People report a chronic feeling of pelvic heaviness, like a persistent sensation that their internal organs are just dragging downward.
That sounds exhausting.
It is. And the literature details frequent reports of air escaping from the vagina during basic exercises like yoga or running. Plus, there's a documented decrease in physical sensation during intimacy.
Which are all massive daily inconveniences, and they sound infuriating. I remember the clinical reviews even quoted patients describing an inability to simply keep a tampon in place.
Right. They noted it feels like a dry tampon is just hanging out, totally unanchored.
Which translates to a massive chronic impact on quality of life. It leads to diminished libido, a huge loss of sexual self-esteem, and severe psychological distress.
Absolutely.
Again, we know people routinely suffer through these symptoms in absolute silence.
Yeah, and that silence really stems from deep-seated embarrassment. And it's compounded by this dangerous societal misconception that urinary or structural issues are just, quote-unquote, a normal part of the sacrifice of having a baby.
Which is an idea we desperately need to dismantle.
100%. And in doing so, we really have to carefully distinguish the sensation of vaginal laxity from the clinical diagnosis of pelvic organ prolapse.
Right, because the sources are very adamant about drawing a hard line between the two, even though they're closely related.
Very closely related. But laxity is the functional feeling of looseness and lack of support.
Whereas prolapse is the eventuality where the suspension bridge actually gives way completely, right?
Yeah.
And the pelvic organs themselves, like the bladder, the rectum, or the uterus, literally drop and bulge directly into the vaginal canal.
Exactly. With laxity, the organs remain largely in place, even though it might constantly feel as though they're falling out.
But laxity is basically the early warning system.
It is the direct precursor. An enlarged levator hiatus is identified in the research as the single most important birth-related factor associated with developing a full pelvic organ prolapse later in a person's life.
And the predictive numbers the researchers gathered tracking these patients over time, they are really alarming.
They built a direct timeline mapping the degradation of the pelvic floor.
Let's share those numbers. Because if someone sustains a relatively normal levator hiatus of around 3.0 centimeters after birth, the estimated median time for them to eventually develop a prolapse is 33 years.
Right. It's a slow, age-related degradation.
But if they suffer an avulsion and are left with a 4.5 centimeter hiatus, that vastly enlarged opening, you mentioned that median timeline plummets to just 6 years.
6 years.
6 years. A biomechanical injury sustained during a prolonged pushing phase leads directly to a catastrophic structural failure of the internal organs less than a decade later.
And that underscores exactly why early identification and intervention for laxity are critical. We can't just dismiss these symptoms as normal postpartum bodily changes.
Right, so we've mapped how the extreme stretching forces of a prolonged second stage cause the pubovisceral muscle to tear, how that tear widens the hiatus, and how that widened hiatus creates lasting laxity.
But a prolonged pushing phase rarely happens in a controlled vacuum.
No, it doesn't. When the timeline stretches into that second or third hour, obstetricians frequently must intervene to deliver the baby safely. And these interventions introduce a massive influx of entirely new mechanical risks.
Yeah. When progress halts, the two primary instrumental tools utilized to assist the delivery are the vacuum extractor and the obstetric forceps.
And the comparative data between those two tools is just eye-opening. For a standard unassisted vaginal delivery, the risk of a first-time mother suffering a levator avulsion hovers around 10 to 20%.
Right. And if a vacuum extractor is used, the risk rises slightly, but it actually remains pretty comparable.
But if forceps are introduced to resolve the prolonged labor, the injury rate absolutely skyrockets. The sources state there is a 30 to 65% chance of tearing the muscle off the bone.
Which is a huge jump.
It is. Why does introducing forceps create such a massive, disproportionate leap in structural damage?
Well, it fundamentally comes down to applied physics and the overriding of the body's natural adaptations.
Okay, how so?
Forceps require the practitioner to apply a significant amount of external force and speed to stretch those pelvic muscles wide enough to extract the baby. So you're introducing rigid metal instruments into an already critically tight, maxed-out space.
So you are literally adding width to the passenger.
You're adding width, and honestly, more dangerously, you are bypassing the slow, gradual descent that allows the tissues to safely utilize their viscoelasticity.
Because as you said earlier, viscoelastic tissue needs time to deform.
Exactly. By pulling forcefully, you're forcing the mechanical stretch significantly faster than the cellular matrix can adapt. And that results in immediate structural failure.
So the very medical intervention deployed to rescue the patient from a prolonged labor actively bypasses the body's safety mechanisms.
Yes.
Which drastically amplifies the risk of the exact structural damage that guarantees long-term laxity.
And unfortunately, the mechanical damage inflicted by that rapid stretching isn't just confined to the muscular cables.
Oh, right. Because muscle is ultimately just meat and connective tissue.
Exactly. The most severe functional danger actually targets the electrical wiring responsible for operating that muscle.
The invisible damage.
Yeah.
We are looking at the body's complex nervous system under extreme duress here. I mean, you read the biomechanical sources and you realize the nerves are being subjected to the exact same violent stretching forces as the levator, Annie.
Yeah. And the primary casualty here is the pudendal nerve.
The pudendal nerve.
Right. This intricate nerve pathway serves as the main communication conduit. It controls the muscles of the entire pelvic floor, and crucially, that includes the urethral and anal sphincters.
Okay.
So during a prolonged pushing phase or an accelerated forceps delivery, the pudendal nerve is dragged downward. It gets severely stretched and it's routinely compressed directly against the hard, bony structures of the pelvis, like the ischial spine.
Man, the research even included 3D computer simulations of the birth canal to show this.
Yes, those models were incredible.
They physically mapped the pudendal nerve's pathway, showing it being pulled circumferentially outward and dragged downward as the baby descends. It visualizes this immense mechanical strain being placed on a highly delicate, millimeter-thin nerve bundle for hours on end.
And when a nerve bundle is subjected to that degree of stretching and crushing force, the myelin sheath protecting it is damaged.
So it stops working.
Basically, it ceases to conduct electrical signals properly. The nerve is effectively stunned. It entirely severs the communication pathway between the brain's commands and the pelvic floor's execution.
Wait. If the pudendal nerve is the only communication line for the pelvic floor and it's being crushed against a pelvic bone for 3 hours, do those lower muscles just go entirely offline after birth?
They can go completely offline, and that manifests in terrifying, immediate clinical realities.
Like what?
Well, the medical reviews highlighted this one specific case study of a 23-year-old woman. Immediately following her delivery, she developed profound postpartum urinary retention.
Meaning she couldn't pee at all.
Right. Her bladder would fill with urine, but because the pudendal nerve was so severely damaged by the stretching forces, her brain was physically incapable of sending the electrical signal down to her bladder muscles to contract and release the sphincter.
God, the daily reality of that outcome is so sobering. The case study notes she had to rely on intermittent catheterization for over 30 days.
30 days.
Imagine surviving the exhaustion of childbirth, bringing a newborn home, and for an entire month, you are physically incapable of urinating on your own because the communication line to your organs has been crushed.
It's awful, and the lack of nerve connection affects the posterior structures equally, which leads directly to fecal incontinence. The anal sphincter simply doesn't receive the baseline electrical signal required to remain closed.
That's just wow.
Now, the neurological literature does show that this specific type of stretch-induced nerve damage is usually temporary.
Okay, so it heals.
It does. As systemic estrogen levels rise in the months following pregnancy and inflammation subsides, the nerve begins a slow process of remyelination and healing.
But that healing process can take months. And during that dormant period, the pelvic floor muscles are deteriorating further because they aren't receiving the constant low-level electrical impulses required to maintain their basic muscle tone.
Exactly. It's a vicious cycle.
So we've covered the biomechanics of a muscle forced to stretch 300%, the tearing of the levator ani widening the central hiatus, the physics of forceps violently bypassing tissue elasticity, and the pudendal nerve being stretched until it shorts out entirely.
It really paints a remarkably bleak picture of childbirth, doesn't it?
It does. But the purpose of exploring this research isn't just to catalog the damage. If someone listening is experiencing this laxity right now, the medical consensus is very clear that they shouldn't just accept it.
No, absolutely not.
So what are the rigorously tested, evidence-based solutions available to restore function?
Okay, so the absolute first-line treatment, universally supported by all the clinical data, is targeted pelvic floor physical therapy, or PFMT.
And it is crucial to note here, this is not just a casual suggestion to perform a few Kegel exercises while driving.
No. It is a highly specific, medically supervised rehabilitation protocol. It's designed to rebuild the muscular integrity of the entire pelvic basin.
And the efficacy numbers in the research for this are actually really compelling. One major study isolated first-time mothers who suffered confirmed levator trauma during their deliveries.
And what did they find?
The cohort that was enrolled in a targeted, rigorous pelvic floor physical therapy program demonstrated a 45% decreased risk of reporting long-term feelings of vaginal looseness compared to the control group.
Wow.
Yeah, a 45% reduction in symptoms from physical therapy alone.
Which is huge. It represents a highly effective, non-invasive intervention that really should be the starting point for any patient presenting with these symptoms.
But looking at the biomechanics we just covered, there's a massive logical hurdle here.
Okay, what's the hurdle?
We spent the first half of this analysis establishing that a levator ani avulsion means the cubovisceral muscle has physically torn completely off the pubic bone. It is detached.
Right.
If the core suspension cable is no longer anchored to the wall, how can consciously flexing it during physical therapy possibly repair the structural tear?
Yeah.
I mean, you can't flex a fully detached bicep back onto your shoulder joint.
That's a great point. And you're right, the physical therapy does not reattach the torn muscle.
Okay, so what does it do?
Well, once the levator ani avulses from the bone, it remains detached unless surgical intervention occurs. But the success of PFMT relies entirely on this elegant physiological mechanism known as the load-sharing principle.
The load-sharing principle. So if the main cable remains broken, how does load-sharing restabilize the bridge?
You have to look at the entire architectural system. The pubovisceral muscle is the primary, thickest cable in the suspension bridge, but it's surrounded by secondary support structures.
Like what?
Things like the perineal membrane, the perineal body, the superficial transverse perineal muscles, and layers of dense fascia. They are all working in parallel to fight gravity and support those organs.
Oh, I see. So when the primary cable snaps, all that weight doesn't just disappear.
Exactly. The load is transferred. The surrounding intact cables are suddenly forced to carry a significantly heavier burden.
So they absorb the extra mechanical stress.
Yes. And by engaging in highly targeted physical therapy, you are intentionally loading and stressing those specific remaining intact muscles. You're forcing them to hypertrophy to physically bulk up, build new muscle fibers, and increase their resting tone.
You are actively training the secondary cables to compensate for the broken primary cable.
You got it. The therapy optimizes the mechanical function of whatever healthy tissue remains in the pelvis. And that, in turn, physically narrows the levator hiatus as much as the remaining anatomy allows, drastically reducing the sensation of laxity.
That is a brilliant workaround. You aren't fixing the irreparably broken element. You are aggressively reinforcing the rest of the bridge so it can withstand the new structural reality.
Exactly. But it's hard work. Physical therapy requires months of intense, grueling effort.
And that's the catch, right? Because patients constantly see marketing materials offering immediate, effortless fixes.
Oh, yeah.
We were talking about the booming industry of quote-unquote vaginal rejuvenation. Clinics offering expensive laser treatments or radiofrequency devices that promise to instantly tighten the tissue and reverse the damage.
And this is a critical juncture where patients really must rely on stringent clinical guidelines rather than cosmetic marketing.
Because the NICE guidelines, which evaluate medical interventions for the UK's National Health Service, they specifically reviewed the efficacy of these heavily marketed energy devices.
And their conclusion was pretty clear.
Very clear. The guidelines unequivocally state that the long-term clinical evidence supporting the use of lasers and radiofrequency for vaginal laxity or structural prolapse is woefully inadequate.
The guidelines actually recommend that these energy-based devices should only be used in strictly monitored research settings, not sold to vulnerable patients as a cure.
Right. And the underlying science explains exactly why they fail.
Yeah, because lasers and radiofrequency devices, they work by inducing controlled thermal damage to the superficial vaginal mucosa.
So they basically heat up the skin layer.
Right. And this heat can trigger a localized healing response. It potentially stimulates a temporary increase in collagen production and blood flow in that mucosal layer, so it might temporarily plump the superficial skin.
But heating the surface skin does absolutely nothing to reattach a torn pubovisceral muscle off the pubic bone.
No, nor does it strengthen the secondary muscles required for the load-sharing principle we just talked about.
It is essentially treating a catastrophic biomechanical failure of a suspension bridge by applying a fresh coat of paint to the surface of the road.
That's exactly what it is.
It looks newer, maybe, but the structural integrity remains deeply compromised.
Right.
So what about actually going in and repairing the bridge with surgery?
Well, reconstructive surgical options, things like a formal vaginoplasty or a perineorrhaphy, they do exist, and they are highly effective for the right candidate.
Okay.
But major pelvic surgery carries its own significant risks, right, including nerve damage, scarring, and chronic pain.
So it's not a first step.
No. The medical consensus reserves surgical intervention for severe cases involving diagnosed advanced pelvic organ prolapse or instances where a rigorous month-long course of physical therapy has just completely failed to restore the patient's quality of life. Surgery is definitely not the starting line for early laxity symptoms.
Makes sense. Let's synthesize the mechanics of everything we have unpacked today. The foundational question was, can a prolonged second stage of labor cause lasting vaginal laxity?
And the biomechanical data answers the definitive yes.
Right. By holding the complex levator muscle under extreme tension for hours, forcing it to stretch beyond its 300% physiological limit, a stress that's often catastrophically compounded by the intense speed and widening forces of obstetric forceps. Alongside severe stretching of the pudendal nerve, the central pelvic hiatus permanently loses its anchor.
Yeah, and that permanent structural widening of the hiatus is exactly what generates the chronic daily physical sensation of laxity.
But by understanding the load-sharing principle, patients can utilize targeted pelvic floor physical therapy to force the surrounding intact muscles to permanently bulk up and take over the slack.
Which significantly narrows the hiatus and restores their daily quality of life, all without falling victim to unproven cosmetic laser treatments.
The entire process really serves as a profound demonstration of the human body's extreme vulnerability under mechanical stress, but also its incredible, almost limitless ability to adapt and compensate when provided with the correct evidence-based rehabilitation.
It really is amazing. But, the research actually points toward a future where rehabilitation might not be necessary at all.
Really? How so?
Well, currently, standard prenatal care focuses almost entirely on the passenger. We measure the baby's estimated weight and monitor the head circumference via ultrasound just to ensure they aren't growing too large for a safe delivery.
Right, we rigorously measure the load, but we spend zero time measuring the bridge it has to cross.
Exactly. But biomechanical researchers are changing that dynamic. They've recently demonstrated that by coupling antenatal measurements of a mother's pelvic bone architecture with high-resolution ultrasound imaging of her specific levator hiatus before she ever goes into labor.
Okay, they can map it out beforehand.
Yes, and they can actively predict the risk of severe pelvic floor injury with an astonishing 80% accuracy.
An 80% predictive success rate based purely on preventative structural mapping. That's incredible.
It is.
So if we possess the technology to accurately map a patient's exact physical limits, then what if, in the near future, standard prenatal care mandated mapping the mother's specific pelvic architecture?
Right. What if we could use those highly accurate ultrasound models to predict and therefore completely bypass these life-altering avulsion injuries before the first contraction even begins?
It would fundamentally alter the paradigm of maternal health care. I mean, we wouldn't just be reacting to nerve damage and torn muscles after the damage is done. We would be planning the entire delivery around the physical reality of the mother's body.
Exactly.
We started this deep dive talking about how the diagnostic X-ray machine for pelvic health is historically murky and reactive. But maybe, if the medical establishment chooses to look closely enough at the structural blueprint before the extreme load is ever applied, we can reinforce that suspension bridge or choose an alternate route entirely so it never has to break in the first place.